check out this new feature called Substack Recording Studio. And so we are going to chat about Jordan's amazing recent Substack where you spoke about testosterone. Is this ever an option? And is this an opportunity for breast cancer survivors, breast cancer patients? So, and I think this is one of the most common questions we both get on our social media, right? Like, can you ever consider systemic testosterone for low libido and maybe other things? Um, and a lot of patients are told, right, no. And why do you think that is?
I think that it goes along with the general narrative that we've had in breast cancer survivorship that, first of all, there's this misconception that all breast cancer is the same, that the treatment afterwards in terms of survivorship and the potential use of hormones is all the same. And I think that you and I both know that that's just not true. We're really talking about a disease that has multiple different iterations. Different staging can lead to different outcomes, and so it's a very nuanced conversation. But I think that the general notion is no hormones forever, and that includes all hormones, whether or not we actually really have a great biological basis for that ban.
Yeah. And so I I agree. I'm so happy that we have this growing kind of group of doctors who are interested in being really upfront and being brave enough to talk about it, right? And so thank you for being part of that. And your Substack opens up with a reference to a great paper that was recently published in the
Okay.
oncology literature by our friends, colleagues, Dr. Linda Bosserman and Dr. Don Dizon, who the title was like, it's instead of prohibition, it should be personalization of this consideration. And we're going to just kind of say what we're going to talk about in the next few minutes is basically we wish we had more data. We know we need more research. But what I tell my patients is if we are going to wait for that perfect randomized controlled study and testosterone after breast cancer, we're all going to be dead. Right. I'm sorry.
Yeah,
It's not happening. We don't even have women's health research in general, certainly not
exactly.
with this. So I say, like, we went to medical school, we could put our thinking caps on, we can use the available data, the big picture, and that's what we're going to do when we kind of talk through your review of the literature. So why don't we start off first? Tell us, like, what is the basic science tell us about what testosterone in just normal breast tissue does? Like, so, putting aside breast cancer for a minute.
Yeah. Well, the way that I structured the piece was really, I think, how we should be talking with all of our patients about really any intervention that we're going to do, which is let's go through what we know, what we don't know, what are the potential risks, what are the potential benefits, and then what does our experience say? And I think you always highlight this so much on your social media feed is that really is the basis for evidence-based care. That we have this idea that, again, it's a misconception that we have to have the perfect, large, randomized controlled trial, double blinded, placebo controlled, every possible way. And I think that, the reality is that a lot of what we do in medicine is actually based on incomplete evidence. And at the end of the day, we really should be prioritizing each person's individual autonomy over their own situation. So, to answer your question, I think just having that basis, when we
Yes.
look at the preclinical data, so just in breast tissue generally, or just people who don't have breast cancer, the data that we have right now would say that women who use testosterone replacement do not show an increased risk in breast cancer. And even in large observational studies that have been done of this, there's actually been shown to be decreased risk of breast cancer among those populations. So I think that that's just an important theoretical basis that we're operating from, that we have yet to see any study that shows an increased risk of breast cancer associated with testosterone use. Specifically in regards to breast cancer tissue, I think that's where it gets really interesting, because I think that, again, we have to go back to this idea of, even just the idea of different hormone receptors being present on breast cancer cells. I think that we have this idea that that inherently means growth, but the preclinical literature would actually not suggest that in laboratory studies, when we look at estrogen receptor positive breast cancer, in general, we actually see that testosterone causes apoptosis or destruction of those cells in the lab. And so there's even evidence that maybe this is potentially leading to a regression of those cells. I don't think we have the clinical evidence, meaning, kind of patients' experience to necessarily show that yet. But I think, again, we have to operate from that biological idea that this does not necessarily mean that there is a growth signal, even if there is an androgen receptor for testosterone on breast cancer cells.
Yeah, and I actually went back and looked this stuff up because, like, we were never really taught what does testosterone do in a menstrual cycle.
Right.
And so looking up what we actually know, the basic science is that the normal physiology of a menstrual cycle where we've got estrogen rise and progesterone rise, and yes, mid-cycle there is a rise in testosterone.
Yeah.
Um, but testosterone counterbalances the growth of estrogen. And this is why I remind patients that your menstrual cycles and all of the hormones that are produced, it's like a beautiful dance. It's a symphony, and they're all, working together. And that actually, as you alluded to, is that testosterone actually kind of counterbalances the
Yes.
growth that estrogen has on breast tissue. And it can increase kind of that cell death, which is a normal part of keeping cell growth in control, right?
100%.
So I think that's really, really important to kind of know that the normal physiology is that testosterone is basically kind of anti breast growth, right?
Yes.
So,
100%.
so speaking of that, what does the data, this is interesting. So, what does the data tell us about using testosterone in women for hypoactive sexual desire disorder, right? So we've got a global position statement on that, that it's very helpful for that. And when we're using appropriate, guideline supported dosing of testosterone in these cases, do we see this conversion to
Right.
estrogen? Because that's like the next thing. A lot of people say, well, if you give women testosterone, it's going to convert to estrogen, it's going to rise estrogen levels. So when you and I are treating patients with HSDD, do we see this tremendous rise in estrogen? What does the data tell us?
Right. I would say that the data and my individual experience is that we do not see that rise in estradiol with the typical dosing that we are using. There is evidence that shows that when we're using significantly higher dosing, like for example, with the example of testosterone pellets, there is an elevation in estradiol in that's suggested in the literature. Now, whether or not that actually translates to any changes in breast cancer risk or breast cancer recurrence risk, I don't think we 100% have the data on that yet. But at least in terms of the theoretical basis, we do not see that at baseline. And then the other part that I'm sure we're going to get to is that a lot of these patients are on aromatase inhibitors, and that is the protein that is converting the testosterone into estrogens. And so, particularly in that setting, even for those high dose testosterone, I guess even for people who are using very high doses of testosterone above and beyond what we conventionally use, the data would show that there is no conversion into higher levels of estrogen in specifically that situation. So that context really does matter because again, it becomes part of that nuance of this conversation.
Yeah, and this is where clinical expertise is
Yeah,
really important part of the picture. You and I basically we have lots of patients who we might have on to not even breast cancer patients who might be on testosterone alone. Maybe they're not on systemic estrogen. I do
exactly.
not see these women have sudden breast tenderness and bleeding because they have all this estrogen converted. When we're using modest doses per guidelines, we don't see that conversion. And aromatase inhibitors, in fact, prevent that conversion.
Yes.
And then, Jordan, the other interesting thing is, and I always remind patients of this, we have lots of premenopausal breast cancer patients out there who maybe are at a lower risk of recurrence,
Mhm.
who have normal menstrual function. These patients, we are not shutting down their ovaries. We're not removing those ovaries. Those women who are, say, in their 30s, sometimes, early 40s, et cetera, they have normal androgens. They're younger, and shutting down their androgens are not a part of treating it. And so, kind of from a common sense standpoint, a woman who is on tamoxifen, right? Um, she we're not trying to lower her androgens. And even if testosterone converted a little bit to an estrogen, what is tamoxifen doing? Tamoxifen is blocking estrogen receptors, right? So I think that's another scenario where it's reasonable to consider it. And then before we get into what some studies on actual use of testosterone in breast cancer patients, what does the data that we have in gender affirming care and in trans men using testosterone tell us about breast cancer risk and testosterone?
Yeah. And I think we always need to remember that we owe, I think, a great debt of gratitude to the trans community for a
Yes.
lot of the safety data that we have surrounding
Yeah.
testosterone. Because, these are people who have, kind of a quote unquote female body physiology who are using significantly higher doses of testosterone than we would conventionally use for a cis woman, and have been using that for potentially decades. And so, what we see in that specific population is that there's no increased risk of cardiovascular disease, no increased risk of breast cancer. And I think these are just really, really, really key things because, again, we're now talking about people who are using significantly higher doses than we would ever use. And so we're extrapolating a little bit, but I think that common sense would suggest that at the much lower doses that we would use in cis women, we don't see that.
And then the other question we should also address is when we're talking about receptors, breast cancer patients get their estrogen receptors tested, progesterone receptors. Testing the androgen receptor is not a common thing that we check, and it might be something that evolves over time. But your piece talks about, what some data shows about ER positive versus patients who are ER negative or triple negative breast cancer in terms of kind of maybe the role of androgens in the androgen receptor. Do you want to just talk about that?
Yeah, I think it's an important caveat. And I certainly always discuss this with patients, that in the evidence that we have, which includes both ER positive and ER negative patients, we haven't yet seen any concern for an increased risk of recurrence. Now, this is short term follow up, but I think that the caveat that we always need to discuss is that there does seem to be a little bit of a different role of that androgen receptor for those two different tumor types. In ER negative tumors, at least again in the lab setting, there is a suggestion that maybe the androgen receptor does contribute towards cell growth in a way that it isn't playing that kind of counterbalance to the estrogen driven growth in ER positive tumors. And I think the other interesting thing is that if you look historically, anti androgen therapy has actually been trialed in patients with ER negative tumors. And my understanding of that literature is that there did seem to be some benefit to doing that. Now, it's not, as I understand it, a standard part of a lot of triple negative treatment plans, but I think that we always need to have that in the back of our mind of, maybe there's a little bit of a biological connection here. And I agree, I think most patients don't have androgen testing for their tumor types. Maybe with very advanced disease, that becomes a part of the testing, but usually we don't know that information going into it. I think going back to how we started this conversation, I think we need to use the best evidence that's available to us, and explain that nuance and explain the gaps and the knowns and the unknowns, and then really come to a conclusion together of what's going to be the best treatment course to make sure that somebody's feeling better and hopefully limiting any potential risk that might come from it.
And let's talk about, I think, two of the papers that you mentioned in the study I think we should talk about here. One is this consensus statement that was
Mhm.
put out by of a team. Sarah Glynn led it, but with a consensus of multidisciplinary. So there was medical oncologists, menopause specialists, et cetera, in this consensus. And really, they basically, it's like a 25-page paper. It's open access. We can link it.
It's
But
become like
basically,
our
they said,
Bible.
would you say?
Become like our Bible. Then,
Yeah, it's a really lovely, like,
yeah,
a
maybe,
framework on how to talk
yeah.
about hormones, and they separate out the different hormones, and in it, it is really worth anybody interested in this looking at what they talked about of the available data on testosterone use in breast cancer patients. And really, it had amongst the best consensus amongst the experts, kind of surveyed in this, that it's reasonable to consider testosterone therapy for low libido. And we'll talk about what else it could help with in a second. Um, and then that's reasonable, really across the board, really in the different types of breast cancer. But the other study is Sarah Glynn, also's piece on the use of transdermal testosterone in women on adjuvant endocrine therapy. So you want to talk about the details?
Yeah, definitely. I don't know what we would do without Dr. Glenn, honestly.
I know she's amazing.
uh, no, I mean she's just produced so much good work that really
Yeah.
helped inform our guidance here. But she had a recent paper that came out that looked at the use of testosterone for a relatively small group of patients in the UK who had a history of breast cancer, many of whom were on endocrine therapy as well. And what they showed in that study is that, while we conventionally think about testosterone being most helpful for low libido, and that's where we have the most data for, we really saw improvement across a variety of menopause symptoms. And I think that the ones that were most prevalent were really the mood symptoms, which is such an important thing to remember and to treat for particularly our breast cancer survivors, who are at baseline are already at a higher risk for mood disorders. So anxiety decreased, depression decreased, also just energy levels was another big area. So but across, kind of a full gamut of menopause symptomatology, we see an improvement with testosterone. And I think that this is such important data because there's still, again, this misconception because the data is limited that testosterone is only good for libido. We have no evidence for anything else. And I think we're starting to see increase in data that's suggesting otherwise. And we would even, I'm sure, you've seen this and I've seen this, that when we start testosterone, we see a lot of other improvements other than just libido. I would even just say that I think that there's something very therapeutic about just having the conversation. That I think that, the testosterone is a really important part, but so many of our patients who we're having these conversations with, they have talked to uh, several doctors, they've talked to their oncologist, they've been told this is just something you have to suck up. This is just something that is a cost of having breast cancer. And I think that you and I are both in agreement that it's really just unacceptable to just completely dismiss these symptoms and say, oh, I'm so sorry, you have to live the next, 20, 30, 40 years of your life in misery. And so I think that just being able to empower people with
Yeah.
good information and with a treatment and something that we know can be helpful is in and of itself so valuable and really is a therapy in and of itself.
Yeah, and so we'll just quickly go through some common clinical scenarios of where
Mm.
how you and I know we practice very
Yeah,
similar. Um, we use a lot of common sense, right? And so you and I both see that most patients asking us these questions, not all, but most of them are generally earlier stage. They feel comfortable having these conversations because they do have an overall good prognosis. And many of them at this point are years from their initial diagnosis, right? So I think those are kind of a little easier to take care of because they've gone through the most common or the most likely time for recurrence, right? Um, and then you and I also see a lot of women who, as part of their breast cancer journey, had their ovaries removed. So I think
mhm,
it's really important for us to always remember that their ovary removal most of the time is because they may carry the BRCA1 or 2 gene.
mm,
So the removal of the ovaries and cutting their testosterone in half was not part of their breast cancer treatment. It was simply to lower the ovarian cancer risk.
yeah,
And so just normalizing testosterone levels to what it was before their oophorectomy, I think is very, very reasonable. So that's like another kind of clinical pearl that I talk to them about. So you and I think both agree, someone who has DCIS,
oh yeah,
who either had a bilateral mastectomy or had an appropriate lumpectomy and treatment, I'm very, very comfortable in that scenario giving them testosterone, because we don't see an increase in breast density. And the other thing is, in these patients, we can certainly, if you're curious about what the testosterone is doing to an estradiol level, can't we just measure an estradiol level?
and that's how I practice as well.
Yeah.
I know that the idea of checking labs, is somewhat controversial, which I find to be a little silly because I think that, we are data-driven people and we should have the data. But exactly, usually I'm monitoring both testosterone, which I think is pretty conventional, but also the estradiol with an ultrasensitive assay. And
Yeah.
I have personally yet to see an elevation in estradiol. I don't know if you've seen it, but
I haven't either. And so this is so for everybody listening, for women who are on guideline appropriate testosterone therapy for low libido, yes, we get a baseline, we measure out 6 to 8 weeks about,
Mhm.
and then at 3 months, 6 months, and then if they're stable, kind of just do it every 6 months just to make sure that they're not hyper physiologic and that they're absorbing it and it's gone up. Fine. So I always particularly my breast cancer patients,
Yeah,
right? Not necessarily in the average woman who's also on systemic estrogen, that's another conversation of whether we need to look at their estrogen levels. But in
right.
this clinical scenario, in someone who is not on systemic estrogen and people are nervous, the medical oncologist is a little nervous, oh, is this going to convert? Well, guess what? We can check it.
Yes,
So what's
exactly.
the big deal? So I actually say testosterone therapy in a
Mhm.
breast cancer survivor who's not on any systemic estrogen is actually really low hanging fruit and actually quite easy to manage. And it's actually not that scary because the thing is, it's something that we apply daily, a daily gel. So we're not putting a high dose pellet in. And we can keep an eye on your levels. And guess what? If you saw them go too high or it was converting to estrogen, well, you could just back down or pause
Yeah.
it. So I feel like it's very, very easy to manage that aspect
Mhm.
of it. Um, so DCIS, you feel okay with.
Yeah.
ER positive patients who are low risk for recurrence and they're just on tamoxifen. If those women are still having menstrual function and their ovaries are still producing estrogen, I actually find a lot of those patients do really well on tamoxifen and may not necessarily need testosterone, right? But what happens is as they go through the perimenopause
Yeah.
and maybe they're
Exactly.
switching into menopause, or if they get those ovaries removed, that's when maybe those symptoms of low libido and low testosterone might kind of kick in and they're kind of curious, can I try it? I think in those cases, I'm quite comfortable using testosterone with them still being on tamoxifen.
And also there's a lot of those patients who will then be switched to an aromatase inhibitor, and I
Yes.
feel like the symptoms associated with menopause of an aromatase inhibitor are much more significant in my experience compared to
Yes.
tamoxifen. So I also find that that's another situation where we're going to be having that conversation of how can we potentially manage that change.
Yes, and then the scenario of a triple negative breast cancer patient, you and I both, I know we tell our patients that triple negative breast cancer patients, their recurrence risk is the most high in the first 3 to 4 years. Once those women reach year 4 to 5, particularly the lower stage, node negative, which are many patients, right? Um, those women may be in permanent menopause at that point because of their chemotherapy, or maybe they are a BRCA1 or 2 carrier and then the ovaries removed. I think when I'm looking at those triple negative patients, if they're out of that more significant window, of risk recurrence, I find, testosterone therapy to be very, very helpful for them,
Yeah.
and I'm quite comfortable. And again, we can monitor levels. Is that how you approach it?
Yeah, I agree. And I think that, even when we just think about, quote unquote conventional HRT, I find that it's a similar conversation.
Yes.
I think that the biggest concern with people who have triple negative or ER negative is more the risk of a new breast cancer, which potentially could seroconvert, meaning that it could convert to an estrogen receptor positive, although that's actually quite rare, which is an important thing that we always need to discuss. But I agree, I think once we're out of that initial window, the recurrence rate of triple negative breast cancer outside of those first couple years is actually significantly lower. An immediate drop off in recurrence risk. So it's a very different conversation than when we're in that initial window. I mean, generally, I will always discuss that with patients, and I usually feel comfortable with a very similar window to what you were saying. But I think also, we have to prioritize where somebody's at, what's important to them. And, I've had patients who are within that window who were discussing testosterone therapy and we're starting it. And we understand that maybe the unknowns are a little bit higher in that time period. But I really want to prioritize, what that individual person is going to want to do with their own body and their own life.
Yeah. And then we should also just mention that testosterone can be used in really low doses, like local testosterone, for
100%.
the treatment of the genitourinary syndrome of menopause. I find, and this is not the same as the doses that we're talking about for to help with like libido. This is not systemically absorbed, and this is typically a compounded estradiol with a testosterone in like a moisturizing base that they can apply to the vaginal opening, the labia, the clitoris. I personally find that patients who are on aromatase inhibitors in particular, but really any menopausal woman with breast cancer or without breast cancer, really benefits because there's a lot of androgen receptors where testosterone binds to. Right, in the vulva. Do you
Yeah.
find that is helpful?
100%. And I mean, I don't know about you, but this was certainly not something that I learned in my training, that there are
No.
significant androgen receptors in the lower third and of the vagina and the vulva.
Yeah.
But exactly, I think especially for, obviously vaginal estrogen always going to be kind of our first go-to. But really, especially patients who are having ongoing symptoms, I agree with the aromatase inhibitor completely. Adding that local testosterone or local androgen in the form of DHEA even can make an enormous difference, particularly for the painful sex aspect of things.
Yes. And
Yeah.
so kind of bottom line is when we're looking at patients, individualized, personalized, and you
Mm.
and I know we start from like the easy things and then we build up. So
Right.
easy things you can add in local vaginal estrogen. You can add in DHEA and local testosterone. Then we can talk about systemic testosterone. And I will never gaslight a patient who tells me that when they had their testosterone, when you give them a little bit of testosterone, I've had patients say, Dr. Men's, of course, many of them feel, it improved their sexual function, but a lot of will tell me, it did, but I feel more energetic. I feel a little bit more focused. My
Mhm.
mood is lifted. And I've had patients pause it and stop it on their own. Whether they just chose to give it a break and just see, and they will tell me, this was not a placebo effect. When I stopped it, I felt a difference. And
Yeah.
when I restarted, I've even had patients restart it even after it not helping their sexual function, because we know testosterone doesn't help sexual function in every single woman, but they restarted it because they just felt better
Yes.
on it, in terms of just overall quality of symptoms,
Mhm.
their kind of day-to-day function, their brain fog, etc. Have you found that?
Yeah, 100%. And I think the other thing that's always important to tell patients is that for a lot of people, testosterone can really be a slow burn. Like for some people, it
Yes.
kicks in right away, but other people, you're checking in with them. It's, maybe 4 weeks, 8 weeks, and they're like, I don't know if I'm feeling much. And then
Mm.
somewhere around the 3, 4 month mark, they
Yeah.
start to notice all of the improvements that you just mentioned. And so I think that it's also important to counsel people on that we may need to work on this for a little bit. We may need to figure out the right dose. We may just need to give it a little bit of time. And that, we're aiming for a long-term improvement here, not necessarily just a short-term gain. And so I think that that is the other common thing that I see.
Yeah, absolutely. And then the last thing I'll say is that I have been um, really happy to see that when I have had these patients, when I approach the medical oncologist, I actually find they're quite open
I agree.
actually to
Mhm.
this. They're actually more open to this than systemic estrogen after
Yeah.
breast cancer. And I understand because we just laid out why there's a lot of
Right.
common sense reasons why I think this is a reasonable approach. And I love the title. I'll end it on that. Is this a lost or a missing opportunity, right? A missed opportunity, I should say, right?
Mhm.
Because I think it is.
Yeah.
It's one tool that I think is underutilized and many people can benefit from.
Right.
So
Exactly. And I think that that's true even of patients who don't have breast cancer,
yes,
but
of
particularly
course.
in the breast cancer survivor and pre-vivor population, we really should be seeking all possible tools to help these people feel better because you and I both know that this is a group of people that is very excluded from the menopause revolution. And I think that it is so fundamental that we find every possible tool we can to incorporate that group into the same benefits.
Yes, absolutely. So we'll link some things. We're going to publish this and we'll link some stuff that we talked to. Go back and read Jordan's full Substack. But thank you for my inaugural Substack
Thank you.
Jordan
Mine too.
studio after we had a couple of little you know
Technologic
problems getting it
deficits.
started,
Yeah.
but we did it. We did it. So I know
Yeah.
you're on call, so you get back
Yeah.
to your
Yeah.
patients.
Thank you.
Thank you so
Thank
much.
you. This was great.